So 23-year-old male, you can see low BMI, he's a Boeing engineer. That usually involves a lot of different questions and having to explain everything a little more detailed than the average patient. So pretty active, pretty standard for at least the Seattle area. So he's had recurrent damage from continuing athletics. It's kind of a 2-year problem. He says worse over the last couple of years. He notices swelling with kneeling, pain and popping with any squatting. Again, not more of a recurrent injury, no previous surgeries. And really his whole main goal was, I want to go back to doing these sports that I love and I just can't do them. Next slide. So again, just jumping around. So my concerns with the story, the 2 years of pain in someone who's pretty young and active is concerning. The popping, but really for me, and because the swelling and locking for someone who's young is not normal. And again, trying other adjuncts, different options, cortisone, hyaluronic acid, PRP. We've chatted about all those things. And then, usually trying physical therapy. And again, he came in having tried those things. And again, worry these symptoms. Again, if this swelling and locking happens, I do worry that sometimes that alone won't treat it, but it's something that still be aware of. And again, most of the time I have my patients at least try it. And you want to be, again, many times the smaller defects are more subtle and they may be completely asymptomatic. So the smaller defects tend to be less symptomatic, the larger ones more. So we start feeling these symptoms, you think about it as a larger defect. All right, next slide. So again, normal standing alignment. In terms of the patellofemoral joint, no previous instability, no J sign. I mentioned before this patellar grind, popping, no real facet pain. So right here, you're thinking this is a really vague exam finding. And for trochlear defects, they tend to have these very vague exam findings and really always hard to pinpoint any direct pain. They usually just kind of point at their knee, at least at the front of the kneecap. So we had a moderate effusion on exam, good range of motion, otherwise everything was stable, and no comorbidities. Next slide, please. So again, first thing in the office is x-rays. So he has this very small spur medially, relatively good alignment. I'm not seeing a lot of subluxation of the patella. And then, you can see from the PA view as well, no arthritic changes. Next slide. So, going on to MRI, we're kind of speed through this. The defect here, and these trochlear defects can be really hard to read. I mean, I was able to see a lot of them, but you don't always get to see all those. So reading these MRIs, especially the trochlear ones, are more challenging. This one measured roughly about 2 centimeters. The biggest thing for me is no bone edema. TTTG, so a little bit off at 13, but nothing majorly abnormal. And CD ratio is roughly 1. Again, this is something I learned definitely from fellowship, is these defects, while 2x2 is already pretty large, they're usually bigger when you end up doing something arthroscopically and evaluating it. And don't write off trochlear defects in general, because it's always hard to fully identify them on MRI. Next slide. So this is the arthroscopy and MACI biopsy. We knew he was going to have a pretty large defect. Initially just going in here, just seeing that right there, and then seeing the patella. And then next slide. And you can see here, just from a thorough debridement, I'm not using a curette or anything, just using a small shaver. I'm able to get a much larger rim on there, and this defect ended up being pretty large. Next slide, please. So, we're not really looking at the meniscus and the other things, but meniscus intact, trochlear defect measured around 2.5 by 2 centimeters. The good thing for here is I always double check the patella, probe the entire patella, because you have a kissing lesion that changes things. And you really want to thoroughly evaluate this. And no other involvement in any other cartilage. Next slide. So surgical plan for me with seeing a defect like this without bone edema, I think this warrants a MACI. There's been really good results. These trochlear patients for me tend to do quite well, and you don't burn any bridges if anything further is needed. Biggest thing to think about is reducing the bleeding at the preparation site and be prepared to put sutures in if needed. But again, with the technique that we have now, you really don't need to do that in majority of cases. Size-wise is important too. Important to be prepared if it's greater than 10 centimeters squared, or it's 2 sites greater than 14, or greater 2 sites greater than 10. You want to make sure that you have an extra sheet of MACI. You can order that pretty easily. And again, in this case, no concomitant procedures, but it's important to be prepared for those if you do have them. Next slide. So this is end up going on to MACI. This is the debridement of the defect, and then we used a pre-cutting guide, and then we're able to place the MACI on there. You can see here we didn't have to use any sutures for him, and I'll show you my technique, but again, I run the knee through range of motion after I finish. If there's any concern, then I'll put a suture in, but in a lot of cases, I don't need to. I tend to do a few more sutures in a patella than I would in a trochlear, just because the defects, the way the borders are of the trochlea, especially the thickness of the cartilage, I'm able to get a little better hold, and I'm a little bit less concerned about it coming off. So OR tips, NeuroSoak patties, you want to have to seal the fibrin glue. I start with tourniquet on, and then I take the tourniquet down to take care of any bleeders. Make sure it's completely dry before starting. I'll show you in the video that we do. And any concerns, you have 6/0 vicryl sutures. And then I run the knee through range of motion because I don't want to leave until I'm sure that defect is going to stay filled throughout the range of motion process, because they usually start CPM pretty promptly. Next slide. So this is a very brief video. So you can see a pre-cutting template. This oval template is usually one of my more commonly used ones. This is a trochlear, not this exact patient. And then they've got these nice curettes, making sure you get a good thorough border. Again, you don't want bleeding at the defect. You want to just go to the calcified cartilage layer. And making sure I have a little, like this little hand curette I really like, because it really gets around those edges. And then you can see making sure your assistant doesn't actually smash the MACI. So that's always important. With the smaller ones, it's a little bit easier. You can see the bottom left-hand corner is where the MACI is facing, so rough side up. And then I use a little top of a specimen cup, put a little bit of the fluid from the MACI, making sure I keep that orientation of rough side up. And then NeuroSoak patties, the tourniquet at this point is down, so we know we're not going to develop a hematoma. So in this patient, there was a little bit of bleeding at one of the little small areas. So I put a little to seal or fibrin glue, and then I apply significant pressure, and that usually stops the bleeding. At this point, after this step, I usually haven't had any issues with bleeding. And there are other little tips you can use. And then I put another round of fibrin glue. And then what I'm going to do is place the rough side down or the shiny side up. And these are the toothless pickups that you use. And then you place that in the defect, just being careful just to really stay on the edges and not damage it. Light finger pressure. I usually do around 1 minute of finger pressure check to make sure I haven't moved the defect, and go to 3 minutes, and then apply another round of fibrin glue. And you can see here, I put it through significant range of motion. It didn't move at all, so I don't need any stitches. All right, next slide. So brace for 6 weeks, CPM. I usually set that pretty aggressively. I try to get them range of motion as fast as possible without damaging the defect. Obviously, if there's a TTO or something else, we go a little bit slower. Really, weight bearing is tolerated with straight leg raise or in locked in extension when they're bearing weight. Range of motion, again, goal is 0 to 90 first 2 weeks. Stairs are avoided for the first 6 months. No real squats for 12 weeks. And most of this stuff is from the MACI website. Post-op status. So he returned at 9 months to all sports. It was incredibly happy. And he went back to basketball, et cetera. No full range of motion, no further swelling. So he was happy with his result. So at 0 to 3 months, you can see where the implant's at. So when you're telling people to do certain physical therapy regimens, it's important to know that, even at 3 to 6 months, this is not fully grown back. And so it's something to understand that, you're not fully remodeled till that 6 to 9. And so it's important to understand that they're still gaining the strength and gaining those things. And when you're seeing these patients at their interval follow-ups, that, they're not going to be immediately better in the first few weeks. It takes a while for the MACI to grow back, and it's very effective, but you just have to be patient and understand why you can't do those heavy squatting until 6 months.
MACI, autologous cultured chondrocytes on porcine collagen membrane, is an autologous cellularized scaffold product that is indicated for the repair of single or multiple symptomatic full-thickness cartilage defects of the adult knee with or without bone involvement. MACI is intended for autologous use and must only be administered to the patient for whom it was manufactured. The implantation of MACI is to be performed via an arthrotomy to the knee joint under sterile conditions. The amount of MACI administered is dependent upon the size, surface in centimeters squared, of the cartilage defect. The implantation membrane is trimmed by the treating surgeon to the size and shape of the defect to ensure the damaged area is completely covered and implanted cell side down. Limitations of use. Effectiveness of MACI in joints other than the knee has not been established. Safety and effectiveness of MACI in patients over the age of 55 years have not been established. Important safety information. MACI is contraindicated in patients with a known history of hypersensitivity to gentamicin, other aminoglycosides, or products of porcine or bovine origin. MACI is also contraindicated for patients with severe osteoarthritis of the knee, inflammatory arthritis, inflammatory joint disease, or uncorrected congenital blood coagulation disorders. MACI is also not indicated for use in patients who have undergone prior knee surgery in the past 6 months, excluding surgery to procure a biopsy or a concomitant procedure to prepare the knee for a MACI implant. MACI is contraindicated in patients who are unable to follow a physician-prescribed post-surgical rehabilitation program. The safety of MACI in patients with malignancy in the area of cartilage biopsy or implant is unknown. Expansion of present malignant or dysplastic cells during the culturing process or implantation is possible. Patients undergoing procedures associated with MACI are not routinely tested for transmissible infectious diseases. A cartilage biopsy and MACI implant may carry the risk of transmitting infectious diseases to healthcare providers handling the tissue. Universal precautions should be employed when handling the biopsy samples and the MACI product. Final sterility test results are not available at the time of shipping. In the case of positive sterility results, healthcare provider or providers will be contacted. To create a favourable environment for healing, concomitant pathologies that include meniscal pathology, cruciate ligament instability, and joint misalignment must be addressed prior to or concurrent with the implantation of MACI. Local treatment guidelines regarding the use of thromboprophylaxis and antibiotic prophylaxis around orthopedic surgery should be followed. Use in patients with local inflammations or active infections in the bone, joint, and surrounding soft tissue should be temporarily deferred until documented recovery. The MACI implant is not recommended during pregnancy. For implantations post-pregnancy, the safety of breastfeeding to infant has not been determined. Use of MACI in pediatric patients younger than 18 years of age or patients over 65 years of age has not been established. The most frequently occurring adverse reactions reported for MACI greater than 5% were arthralgia, tendinitis, back pain, joint swelling, and joint effusion. Serious adverse reactions reported for MACI were arthralgia, cartilage injury, meniscus injury, treatment failure, and osteoarthritis. For more information or to view full prescribing information, please go to maci.com.